बेस्ट ग्रेटिट्यूड one from the bottom of my heart. तो मुझे याद है कि बहुत से लोग तो यहाँ पे MD मेडिसिन करके they are alumni, but I entered in 2000 in this prestigious institute and I taught ABC of the medical sciences from all esteemed faculty. और जो सबसे इम्पोर्टेंट चीज़ जो जीवन में सीखी वो जब हम वहाँ पे रेजिडेंट थे तो जैन सर बस और HOD और हमेशा से सर का ये था कि ये काम हमें फर्स्ट टाइम करना है. जो भी चीज़ें हमने अपने डिपार्टमेंट में की वो फर्स्ट टाइम की, वो सर का विज़न था. वो चीज़ समाओ मेरे साथ रही और आज भी है कि बहुत सी चीज़ें जो नहीं आती हैं वो फर्स्ट टाइम करना है, ऐसा रहता है. और कुछ आप लोगों के आशीर्वाद से सर को, आप सब लोगों को भी मैं जब भी कोई अचीवमेंट करता हूँ तो आई यूज टू शेयर लाइक ए स्मॉल किड. तो आज जो टॉपिक है दैट इज़ अ डिफरेंट मॉलिक्यूल दैट इज़ एक्चुअली इंट्रोड्यूस्ड इन इंडिया रिसेंटली 6 months बैक, and the name is inclisiran and it is a PCSK9 inhibitor. Although this drug is costly, but the early results are very encouraging and very promising. So I have used the 6 injections of this molecule to the 6 patients of the high risk atherosclerotic disease. And today I will share my experiences, what is the importance of the lipid management in the high risk patient and how this drug is going to act and what is the results. And again in the after the completion of this thing I will shortly show my a case that is known as the renal denervation therapy, and it was the 5th case of India and first case of the Uttar Pradesh that I have done. I would summarize into the next 5 minutes. So the importance of the LDL-C cholesterol. We all know that the LDL-C cholesterol levels is now one of the most important marker of the atherosclerosis. If you see the patient of the acute coronary syndromes, if you follow the 1 year, and most of us are giving high dose statin to the patient of the acute coronary syndrome for at least 1 year, you will see that the LDL-C level 70 is achieved only in the 55% of the patient, and 79 less than 55 of the LDL is 79% patient do not achieve the target LDL-C. So the data is very important, and this data basically tell us that what is the importance of the lowering LDL-C level, and then we are very much lacking despite of the best possible medications. So if you categorize that, how you decide that the what level is suited or what level is being the marker of the which patients. So the low risk patient, you can say like all a particular subset of the patient, the LDL-C level should be less than 100. In the high risk patient, who are the high risk? Diabetes patient, CKD patient, homozygous familial hypercholesterolemia patient, hypertension or more than one risk factor, or target organ damage. In these subset of the patient, you should follow the target level of the LDL-C by less than 70. Very high risk patient, that ASCVD patient, if you are going to the angiogram of that patient and the patient is having more than 50% lesions in the angiography, diabetes since a long, and this familial hypercholesterolemia and CKD. These patients are categorized as the very high risk patient, and your target LDL level should be less than 55. Then again, extremely high risk patient, that patient who is having recurrent episodes of the acute coronary syndromes. Suppose a patient comes with anterior wall MI, you have done the angioplasty, and after 6 months alike, so they are having the second event, you do the angiogram and find that there is a stent re-stenosis or there is some different atherosclerotic diseases there. These patients are categorized as the extremely high risk patient, and in that subset of the patient, LDL-C level should be less than 40, and this is the standard CSI 223 guideline. So if you simplify this, you have to basically chase in the high risk patient is the LDL-C level, it is less than 55, and extremely high risk patient less than 40. And recently Lipid Association of India have recommended that the less than 30 is the best target that you can achieve. So if you see the treatment is very simplified. Most of us the follow like the same thing, that if you are encountering any ACS acute coronary syndrome patient, and if you are taking the history of that patient and patient is not taking any kind of the lipid lowering therapy, definitely all of us is giving the high dose of the statin like atorvastatin 80 milligram. Some of us use the atorvastatin 40 or rosuvastatin 40 or 20 milligram. And then we used to see the lipid levels. And then if you are not finding the target levels, you can add some therapy like estimabine. It is again a class 2B indication. And then after 4 to 6 weeks, you can analyze the lipid levels. And still, if the lipid level is not achieving the target of 55, you can use some other drugs. I will tell you what is the other drugs. Again, if you are encountering the patient who is acute coronary syndrome and admitted with the re-ACS, and if the patient is taking the statin, you evaluate the patient. If he is not in the optimal treatment of the dose of the statin, you can up-titrate the statin dose and you can add the estimabine. Some doctors are using the bempedoic acid. Again, bempedoic acid is having some promising data and some results. But again, you can add the bempedoic acid and estimabine as an add-on therapy, and target level should be less than 55. But the question is next, if despite of your best attempt, you are not achieving the goal of less than 55, then what is next? What is the next pipeline of the therapy? And the next pipeline of therapy is like, if you go this data shows that each millimole per liter reduction of the LDL-C reduces the relative risk of ASCVD 10% by 1 year, 16% by second year, 20% by 3 years. There is the large registry, but again you can see even up to 3 years you are going to reduce 20% of the ASCVD risk if you are achieving the goal of this less than 55. So now what is the therapy? We all know that the statin are the gold standard of the treatment. Some use atorvastatin, some use rosuvastatin, then the estimabine come, and then again bile acid sequestrant. The newer therapy is PCSK9 inhibitor. Most of the tier 1 or 2 cities in which it is approved in the CGHS scheme, and it is used like twice in a month injection, or 26 injection you have to take for 1 year. So it is a subcutaneous injection. I suppose Dr. Sajid is well aware of that.
I am using.
Probably you are using because you are associated with the SBI guys. So again, apart from that, evobrutinib, that is the new therapy that is I am going to discuss, that is known as the inclisiran. Inclisiran is a modified version of the PCSK9 inhibitor. Again, it is a act in a different manner, and it is the inhibitor of the small interfering RNA. So I am going to tell about this thing. Some therapies are still in the pipeline. In the future, you will see that there must be some vaccine for this. There must be some long-acting LDL-C reduction molecules. So this slide is very important. You can take the picture of this slide because I will mention it again. This is a slide which predicts how much LDL-C reduction you will achieve after giving the various treatment. If suppose a patient is having LDL-C level is like 200 in the baseline, atorva 80 or rosuva 40 milligram, you will achieve only 50% reduction. If you add estimabine, you will achieve 65% reduction. If you give only PCSK9, you can achieve 60% reduction. And if you add all the possible medicines like PCSK9 inhibitor plus atorvastatin 80 plus estimabine, you will predict 85% of the LDL-C reduction. So if you encounter the patient of the acute coronary syndrome and you are then the standard guideline that right from the day when you can have a lipid profile of that patient, and suppose if the lipid profile is like 200 and you are imagining that if you are going to give the high intensity statin, it is not going to achieve the target lipid levels. So it is very clear that this chart is that how much reduction you can get by introducing the which dose and which treatment options. Similarly, there was some landmark trial of the atorvastatin, that is miracle trial. Simvastatin is A to Z trial, and they showed that the earlier is the better. Atorvastatin shows that if you introduce atorvastatin 80 mg per day in the first initial 16 weeks, it is going to reduce the major outcome. Similarly, simvastatin has the same results. So again, the study continues, and they came to know that if you are adding the additional PCSK9 inhibitor within 4 weeks of the acute coronary syndrome, that I am mentioning, the name is Ripatha, and it is probably Dr. Sajid, who is the maker of that molecule?
Dr. Reddy.
Dr. Reddy's, yes. Dr. Reddy's is actually manufacturing it. So, if you are adding this PCSK9 inhibitor, it is going to reduce the major cardiovascular outcome 95.7% in terms of the mortality, recurrent acute coronary syndrome, and repeat revascularization. So again, evobrutinib is definitely a future of the LDL-C reduction, and we are heading towards it. And there is a very much sounder data that it is going to achieve the target LDL-C level. ACS, definitely it is going to reduce the mortality and the primary endpoint. Now I am talking about the PCSK9 inhibitor. It was introduced by the Fourier trial. It is having the 61% reduction of the LDL-C level, 18% reduction of the major coronary event, 23% reduction additional PCI, 24 reduction PCI at de novo lesions, and PCI 24% reduction PCI at the previous stented and the previous grafted vessel. So definitely PCSK9 inhibitor is the one of the upcoming tools in which we can reduce the future atherosclerosis this event, and again this is a very sounder data. Now I will come to the topic that is known as the inclisiran. Inclisiran is the recently introduced drug which is a siRNA inhibitor. It acts on the hepatocyte. So what is the difference between that molecule Repatha and the inclisiran? Actually Repatha is a monoclonal antibody. It blocks the antibodies in the that against the LDL, but the inclisiran is the one step ahead. It is actually acts on the hepatocyte directly, and it inhibits the siRNA, and so it basically inhibits the production of the LDL, and it is only in the hepatocyte, not in the brain. So siRNA is most impactful molecule as of now because it directly acts on the hepatocyte. So if you compare the possible options, the statin, definitely you have to take once daily dose, 365 days per year. Second one is a PCSK9 inhibitor, that is Repatha. You have to take 26 days per year, means roughly 2 injections per month. And if you take inclisiran, you have to take only 2 doses in a year. So this is a very sounder data. There is no any genotoxic effect, any carcinogenic effect. This is a very safer molecule and very much sounder data in terms of the LDL-C goal. Inclisiran achieved mean more than 50% reduction in the LDL-C level in the phase 3 study. It is going to reduce mean LDL-C level change from the baseline 50%, LDL-C level 55%, and again the non-LDL-C and all these levels. So the results and the data is very much promising. There was some trial that is known as the Orient trial. Orient trial has validated the inclisiran in the various perspectives, and there is a large registry that is a compile of all these Orient trial, and it shows that the 78.4% patient achieved the pre-specified LDL-C target in the end of the study. 90% patient achieved their global lipid target in any visits, and average LDL-C reduction was reduced by 50% in the end of the study. So you can imagine that the how much effectively this molecule is going to reduce the LDL-C level, and we all know that it is directly related to the adverse outcome or any ASCVD events. So the regimen that is proposed by the company is the initial dose first, then after 3 months you have to take the second dose, then after 6 months you have to take the third dose, and then after every 6 months you have to take the another dose. But somehow, what is my experience with this molecule, Indian patients are the super responder patient. I will give you the data, real time data, but most of my patients do not need the second dose. I give the third dose directly at the 6th month. So my experience with the inclisiran, I use in 6 patients till now. It is highest in Uttar Pradesh. All are the high risk recurrent acute coronary syndrome patient, and the results are encouraging. I will choose only 2 patients just because of the short of the time. The first patient was a 48-year male. He was having the acute coronary syndrome 1 year back, coming to me with again history of the acute onset chest pain. Again ACS non-ST elevation MI. I did the angiogram. The stent of that fellow was re-stenosed, and there was a fresh lesion that was appeared. So I did again the PCI of that patient. So I did the PCI to the LAD, and then a treatment that is known as a drug-eluting balloon. It acts when you are having a in-stent restenosis. So I did the plasty of the LAD and depth to the this RCA, right coronary artery. I asked that patient, I went to the previous papers of the patient, he was taking the low dose of the atorvastatin. So the idea is just you have to escalate the dose first, then re-evaluate the lipid levels, and then you have to give this therapy, because this is not a first line of therapy, you have to add on this therapy. But when I asked that fellow that why you are taking this low dose of the atorvastatin, he told me that whenever my doctor escalate the dose of this statin, my liver enzyme is decreased. So the message was very clear that patient was a statin intolerant patient. So what is the option? A patient who is having acute coronary syndrome within 1 year, in-stent restenosis, other vessel disease, statin intolerant, what is the another option? The only option is to use the inclisiran. Now you can see the SGOT level is 69 and SGOT level is 119, SGPT is 69. And the LDL-C level of that patient was 84. Again, it was not achieving the lipid targets. So I gave that patient to the inclisiran, and you will surprised to know that after 6 months of the therapy, actually I gave that therapy to the March 24, and then I repeat after 3 months to just evaluate for the further doses. The LDL-C level was 0. And SGOT, SGPT was, again, it was normal, 41 and the 36. So patient was not need to take that dose in the 3 months, and again I decreased the dose of the rosuvastatin for the further 10 milligram, and still after this you can see the real time that investigation that I have carried, the LDL-C level was 0, and then again after 3 months the LDL-C was I'm not clear, it is 10. So after 6 months of the therapy with the single injection of that patient, the LDL level was still less than 55, even 0 and 10, and patient is having only 1 dose. The second dose we are waiting to give. I asked that patient to just wait and go for the further lipid profile for another 3 months, and we will evaluate it. Second patient was per se is a doctor. He was a very much high rated physician of that city. He was having, and there is no history of diabetes, no history of any hypertension. Present with acute coronary syndrome, and I did the angiogram. The circumflex artery was actually a disease. I put the drug, this biovascular absorb, that is a new stent. It dissolves inside the body, and it is designed for the younger patient who supposed to live longer, and we just want to secure the revascularization option of that patient. So I did the BVS to that patient, and again I came to know that he was actually taking the statin from his own, just because of the fear of this thing. So LDL-C level of that doctor was 92. So again I just started and continued the rosuvastatin 40 milligram, and then I introduced this inclisiran to that in the March 2024. So again, the LDL-C level that you can see, the LDL-C level is 45 at that after the 3 months of that inclisiran uses, and recently the second report of that doctor was LDL-C level is 26. So we achieved the goal of the LDL-C level. Patient was actually doctor, and he was very much concerned regarding this re-stenosis or further atherosclerosis. So he was motivated by himself. 3 days back he came to my hospital for the next doses of the inclisiran, and he was very convinced with this. So this is the real time test of that patient. So the key takeaway of that, my experience with this all the 6 patients, that definitely we are very convinced that the acute coronary syndrome is directly associated with the LDL-C levels. Somehow we are not so much vigilant about the LDL-C level of our patient, but the guidelines are very stringent. They show that the LDL level C should be rigorously observed to your patient. If you are treating any patient of the ACS, even high risk patients, it should be by any means less than 55. We have the traditional option of the statin, now estimated by barbampidic acid. After the uses of all 3 possible medicine, if your patient is not achieving the goal and the patient is presenting with the new lesions, new re-stenosis, then before this there was no drug to this thing. Dr. Reddy's has introduced this medication Repatha, but this is the different mechanism of action, and patient has to take twice injection subcutaneous for indefinite time. But definitely with the introduction of this new molecule inclisiran, there is a ray of hope to that subset of the patient. And you will surprised to know that most of the Indian cardiologists willingly started taking this inclisiran, because most of the doctors, they believe that there is some compliance issue. They used to forget the regular dose of the statin, and they are very much cautious about their atherosclerosis and their outcomes. So it is very much now popularizing in the India that they are very concerned, and the results are very promising. You have to take a single subcutaneous dose and it will work for another 6 months like so. So now this is the very early phase in the India. There are a lot of questions regarding this. So what are the challenges and what is the goals to ensure the early aggressive lowering therapy? Would you escalate lipid lowering therapy right or after discharge? Do you manage the lipid variability associated with the poor adherence to the long-term lipid lowering therapy? And in your practice, do you compare the inclisiran to the other established lipid lowering therapy? Again, it is I am much agreed that that is a very initial phase of this molecule. There is lot of things to work on this in this molecule, but definitely the results are very encouraging. We are very much promising, and since we are working in a corporate sector in the Lucknow, so most of the public sector units, the patients are mainly this. Insured by the companies, CGHS schemes, railways schemes. So most of the time, right now I incorporated in my practice that I used to see LDA each and every high risk patient. So I have to just put an explanation letter to that particular company, and they issued for this insured patient. Definitely the price is constant. The price is like 1.25 lakhs. So it is not possible to take from any patient his own pocket. But definitely any molecule who is introduced in the India, initially it is definitely the price is definitely
One injection 120, 1 lakh 20.
1.25 yes.
और ये किस कंपनी का है?
Novartis.
Novartis का है और Mankind marketing ले रही है.
Abhi right now the Mankind and Lupin and Dr.
आने वाला Mankind का आ गया.
3 companies have again taken the selling rights from the Novartis. So this is all from my side.
Thanks, Dr. Gautam, for delivering such a wonderful
I will
talk.
take only 5 minutes for. I know we all are running short of time. I will just take only 5 minutes just to see a new thing. So this was the renal denervation case that we have recorded from the Tenderpalm Hospital. Dr. Adesh is here. He is also my senior, and he is basically accompanying me in this particular case. We have recorded this case live, and it was the first case of India that was recorded live of the renal denervation therapy. So I am just taking renal denervation therapy. The background is the patient actually that going to do the second case of renal denervation therapy of Uttar Pradesh. The first, I am muting it. Basically, what is we all know that the resistant hypertensive patient, if your patient is taking 4 or more than 4 drugs, and you see that the BP is not controlled, then what you will do? Most of the patients are landing into the CKD, rising creatinine levels in front of you. If not both the things, but you will find that there is the vast variation of the blood pressure control. Most of the time you educate the patient like 8 बजे दवा ले लो, 2 बजे ले लो, शाम को बढ़ जाता है तो शाम को ले लो, and most of the patient are basically land into the CKD and end-stage renal disease, various other cardiovascular outcomes, various stroke, hemorrhage. So before that there was no study regarding to this thing कि इसके बाद क्या करें. So the concept is like कि रीनल डिनर्वेशन की एक कॉन्सेप्ट है कि जो रीनल एंजियोटेंसिन सिस्टम होता है, जो रीनल एंजियोटेंसिन सिस्टम है वो बेसिकली किडनी के आर्टरीज के ऊपर से निकलता है. सो दिस इज द फिगर दैट यू कैन अंडरस्टैंड. दिस इज द रीनल आर्टरी, एंड रीनल आर्टरी के ट्रंक के ऊपर से जो है वो रीनल सिंपैथेटिक सिस्टम जो होते हैं वो जा रहे होते हैं. इफ बाय एनी मींस इफ वी कैन एब्लेट द रीनल आर्टरी, the heat produced and this blunts the sympathetic nervous system, and subsequently they blunt the RAS system. So what the telmisartan and ramipril, all these drugs it is acting like the same, but they permanently shut down or ablate the renal angiotensin system. by giving the radio frequency ablation. इसके ट्रायल्स जो शुरू हुए थे वो सबसे पहले सर ने बताया कि द ट्रायल्स स्टार्ट वेरी मच अर्ली, दैट इज नोन एज द सिंप्लिसिटी 1 ट्रायल। तो उसमें क्या था कि जब हम लोग यूज करते थे तो पहले जो एक कॉन्सेप्ट था कि जो मेन रीनल आर्टरी है उस रीनल आर्टरी पे हमें रेडियो फ्रीक्वेंसी एब्लेशन देना है। बाद में धीरे धीरे उन्होंने इसको आगे प्रोग्रेस किया, फिर उन्होंने देखा कि जो मेन रीनल आर्टरी है वहाँ पे रेनिन एंजियोसेंस जो नर्व्स होती हैं उनकी डेंसिटी कम होती है, डिस्टल बेड्स पे ज़्यादा होती है। वी शुड मोस्ट फोकस ऑन द डिस्टल रीनल बेड्स रादर देन द मेन रीनल ट्रैक्ट। तो उन्होंने उसके हिसाब से एक कैथेटर को डिज़ाइन किया जो 360 डिग्री कैल्शियम 360 डिग्री पे उसकी फॉर्मेशन थी और देयर वर 4 इलेक्ट्रोड्स फॉर द इफेक्टिव रेडियो फ्रीक्वेंसी एब्लेशन। सो द ट्रायल प्रोग्रेस विद द सिंप्लिसिटी 1, सिंप्लिसिटी 2, देन सिंप्लिसिटी 3। द लेटेस्ट ट्रायल इज द सिंप्लिसिटी 3 ट्रायल्स एंड सिंप्लिसिटी 3 ट्रायल्स के रिजल्ट्स जो है वो न्यू कैथेटर के साथ बहुत प्रॉमिसिंग थे और ये देखा गया कि बहुत सारे पेशेंट्स को इससे आगे चल के फ़ायदा हुआ और करीब 28,000 लोगों की रजिस्ट्री डेटा नाउ इट इज़ अवेलेबल एंड इट इज़ रिसेंटली इंट्रोड्यूस्ड इन द इंडिया। सो आई डिड द फर्स्ट केस ऑफ यूपी few days back and now the second case was again done by me. So it was actually went live. So the patient selection criteria actually is very important. As of now, renal denervation therapy is class 2B indication in which any patient is having EGFR more than 40, uncontrolled BP and all the possible medicine. Then this was the patient that I have basically used. I am just going to end it. 56-year female, hypertensive, hypothyroidism. CT angiography shows normal coronary, secondary hypertension. It is essential to rule out that any secondary cause of the hypertension. We did the renal Doppler. There was no evidence of the renal artery stenosis. The blood pressure of that lady was 200 by 108. In the OPD visits, we put that patient in the ABPM. The ABPM means ambulatory BP monitoring shows that 170 by 100 just to rule out the white coat hypertension. And the lady was having recurrent LVF, admitted 2 times in 1 month and managed with the BiPAP support. She was taking Nicardia XL30, telmisartan, cilnidipine hydrochlorothiazide twice, isolazine twice, surcamine twice, metoprolol once a day, and Ditor plus. In all these medications, the lady was having blood pressure was like this. So we just rule out the secondary causes and we basically incorporate that patient for the renal denervation therapy. So what is the next option? Definitely this is the renal denervation therapy. So we just went to the renal artery. This was the 4 catheter that go inside the renal artery and then we start giving energy from the outside and then it starts ablating by this thing. So in the last we have given the both kidney treatment and then we check the renal angiogram of the patient, and in the next time when we will have time I will describe in detail, but these results are very promising. Right now this lady we have reduced the drug to that lady. She is taking only triple drug combination single a day and the results is very promising. I am very much looking forward to it. Right now I am a national proctor for this. I was intended to go this Schemes Institute Kashmir for this therapy, but I was basically committed sir to that I will come here, so I postponed that case actually. But I am very much looking forward to it that we will do some good things with this renal denervation therapy. Again, I am very much proud and I am having very deep respect to all of you, Jain sir, Navneet sir, Praveen sir, Sagar sir, and all of you, that I am the product of this institute, and I just pray to God that you remain healthy and you should remain showering your blessings to me. Thank you.
वो कहते हैं कि नहीं बदल सकते हम खुद को औरों के हिसाब से, एक लिबास हमें भी दिया है खुदा ने औरों के हिसाब से। वो है हमारे गौतम स्वरूप साहब।
Which sir done the trial of the patient, 28,000 patients data. It is actually very much frequent in the Singapore and the European country as well. उनका तो ये भी कहना है कि यदि कोई यंगर पेशेंट है और वो बोलता है कि मेरे को नई दवा खाना है, then you can offer this therapy to that subject.
So simplicity 1, simplicity 2 failed because of
the design of the catheter. क्योंकि पहले वो दो गलतियां करते थे, वो सिर्फ मेन रीनल ट्रैक में एब्लेट करके बाहर आ जाते थे।
right.
फिर उनको धीरे धीरे ये जाना कि जो डेंसिटी ऑफ द फाइबर है वो डिस्टल पे ज़्यादा है, एंड दैट यू डोंट हैव टू गो टू द वेसल दैट इज लेस देन 3 मिलीमीटर, बिकॉज वहाँ पे पेरेंटाइमल इंजरी हो सकती है। यू हैव टू टारगेट 3 मिलीमीटर एंड मोर वेसल, एंड दिस रिजल्ट्स इज द परमानेंट, नॉट फॉर द टेम्पररी, एज पर दैट देयर
What is the maximum for?
डूइंग इट वेरी रेगुलरली। जो रिसेंट डेटा आ रहे हैं वो ये भी कहते हैं कि इवन इन द आप हो सकता है आगे वाले टाइम में देखो कि एंड स्टेज रीनल डिजीज में भी हम इस थेरेपी को देना चाहते हैं, बिकॉज जस्ट टू अवॉइड द फ्रीक्वेंसी ऑफ द डायलिसिस और द फर्दर प्रोग्रेशन ऑफ दिस थिंग,
Because
बिकॉज
the background of this, then renal autoregulation of blood flow, which demands.
दैट इज अगेन अ
on
थ्योरी।
every
यस,
day-to-day basis.
समटाइम्स ये बोलते हैं क्योंकि रीनल सिंपैथेटिक सिस्टम एक अच्छा सिस्टम है, बॉडी के लिए भी अच्छा सिस्टम है क्योंकि वो स्ट्रेस रिस्पॉन्स को प्रोड्यूस करता है। बट उनका जितनी भी स्टडीज हुई उन्होंने ये देखा कि हार्ट फेल्योर की जो मैकेनिज्म है वो उससे प्रभावित नहीं होती, इट डू नॉट अफेक्ट दिस, इट सिंपली ब्लंट्स द रिस्पॉन्स, सो दैट कि ये भी नहीं बोलता है कि आप दवा को बंद कर सकते हैं। जो ट्रायल देखे गए 3 इयर्स के अंदर 20 से 30 मिलीमीटर का रिडक्शन था उनके पेशेंट्स में, बट समहाउ इंडियन डेटा इज वेरी मच प्रॉमिसिंग।
लेकिन डिनर्वेशन के बाद रीनल परफॉर्मेंस वाज
परफेक्ट। देयर वाज नो, मैंने जो फर्स्ट केस किया था दैट वाज एन एनेस्थेटिस्ट, वो उसका क्रिएटिनिन लेवल राइजिंग ट्रेंड में था, उसको हुए करीब 1 साल हो गए, आज भी 1.7 क्रिएटिनिन है दैट फेलो।
Is this radio ablation damaging sympathetic nerves or RAS system?
Actually it blunts the afferent nerves, तो जो सिग्नल्स afferent nerves के थ्रू ब्रेन में जाते हैं वो ब्लंट हो जाते हैं। So the brain response intact, that is what I am saying. The brain response is intact, but the effect that transmitted from the kidney is blunt actually.
Is it through SNS, sympathetic nervous system?
Yes.
Or through RAS, renin angiotensin aldosterone system?
No, it is the sympathetic nervous system that activates brain and then further.
By giving the statins.
जो कैथेटर था उसमें केवल एक इलेक्ट्रोड था, जो सिंपलिसिटी और 1 और 2 का जो ट्रायल था उसमें इसमें 4 है और वो ऐसे डिजाइन है
पूरा 360
yes, और अगेन इसके अंदर एक एआई बेस्ड टेक्नोलॉजी है कि अगर वो एब्लेट नहीं करता है तो मशीन ऑटोमेटिकली स्विच ऑफ हो जाती है। दैट टूल के आपको री एब्लेशन वापस करना पड़ेगा।